Hi, I'm Scott Baginski, a vRad radiologist and medical director, and in this presentation we're going to talk about some more great calls. In radiologist parlance, a great call is when someone makes a particularly subtle finding or a difficult diagnosis or maybe even an uncommon diagnosis. The question was posed, what's the most frequent great call submission from radiologists by their colleagues? We read a lot of non-contrast head CTs, so maybe the most frequent great call submission comes from those. Let's roll through this non-contrast axial head CT. This was done for seizure. Perhaps you made the finding as well. The finding is on this axial slice. If you draw your attention to the left caudate and putamen, you'll see that they are relatively hyperattenuating compared to their contralateral counterparts. The finding is easier to detect on stroke windows. Again, the red circle demonstrating the relative hyperattenuation of the caudate and putamen on the left. The radiologist sought out additional clinical history, and the seizures were described as right upper extremity involuntary writhing movements. The patient was a type 2 diabetic with a blood glucose level of over 700. A diagnosis of non-ketotic hyperglycemic hemichorea was made. So the findings were subtle, the diagnosis is rare, which makes this a great call. Here is another case of the same diagnosis that was submitted as a great call. This time the findings are seen on the right with relative hyperattenuation of the caudate head and subtly the putamen. Although it's certainly a great call, it's not the most commonly submitted great call just because the diagnosis is pretty rare. Perhaps this is the most commonly submitted great call. We certainly read a lot of chest x-rays. And the finding here is a very subtle pulmonary nodule at the right mid-lung. It's confirmed. There's a coronal CT showing a spiculated solid juxtapleural nodule with some pleural retraction. Here's the axial CT showing that spiculated nodule. So certainly this is a very difficult finding to make prospectively on the plain film, but it was made and it is a great call. However, it's not the most commonly submitted great call. Perhaps the most common submission is a corner of the film finding. Let's look at this lumbar spine CT. The indication on this lumbar spine CT was low back pain, displacement of lumbar disc with radiculopathy. So there are the axial images. Here's the sagittal reformat. You can certainly see at L4-5 there's a degenerated disc with vacuum disc phenomenon, grade 1 anterior listhesis of L4 and L5. It's straightforward to make that diagnosis. You've got directed clinical history. The examination is focused directly on the problem. But if we look outside the lumbar spine, we'll roll through the axial images again. That's where the great call was made. No, it's not the left renal cyst. The great call was made on this image, again, non-contrast. If we place it on liver windows and direct your attention to the right posterior liver, you'll see a hypoattenuating, ill-defined hepatic mass, which was certainly a great call, very clinically significant. Here it is on the follow-up contrast-enhanced abdomen CT. There's an ill-defined, peripherally enhancing mass, centrally hypoattenuating. There's highly FDG avid on PET. This is a cholangiocarcinoma. Again, a fantastic call as the finding is outside of the focus of the examination. In this case was the lumbar spine. We've come to the most frequently submitted great call. It occurs on a common study, the abdomen CT. It's often a corner of the film finding. It's often a very subtle finding, and it is certainly clinically important. And that is the pulmonary embolism seen on an abdomen CT. So let's talk about how to diagnose a pulmonary embolism on abdomen CT so everyone can make these great calls. First, you can use your checklist approach of a very routine, anatomically directed, methodical search pattern to look directly at the pulmonary arteries. That'll give you a great chance at catching these. If you don't see it directly, you can use the secondary signs of a pulmonary embolism. The easiest way to diagnose a pulmonary embolism on an abdomen CT is to look directly at the embolism. It sounds obvious, but it's easier said than done. There's often the temptation on an abdomen pelvis CT to gestalt the lower chest images and then do your anatomic checklist through the abdomen and pelvis. I'd recommend against this. For example, the things that are on my regular chest CT checklist that I can see on this abdomen CT are the heart, the coronary arteries, the pericardium, mediastinal spaces, esophagus, aorta, the pleural spaces, the pulmonary arteries, the pulmonary parenchyma, the bones, and the soft tissues. So I'd recommend still use your normal chest CT checklist on the imaged lower portion of the chest on an abdomen CT. I've seen some structured reports that will encourage using the Gestalt approach where they'll have a finding header that just says lower chest. I would try to avoid that. Let's see some examples where the only way you're going to make this diagnosis is to look directly at the pulmonary arteries. Here's another case that was submitted for great call. I'll draw your attention to the right main pulmonary artery. There's some subtle hyperattenuation here. If we put it on liver windows, it makes it more obvious. If you put a green arrow on it, it makes it even more obvious. So there were no secondary signs of a pulmonary embolism on this examination, only this hyperattenuation, which you would only be able to see if you were looking directly at the pulmonary arteries. This is the follow-up chest CTA, which shows the thrombus in the right main pulmonary artery. Let's look at another example. This example is actually from a neck CTA. The indication was vertigo and code stroke. So obviously, there's a lot of streak artifact and motion on this examination, and I'd argue if you don't directly look at the pulmonary arteries in a checklist fashion, then you're not going to be able to spot this PE. This is an abdomen pelvis CT done for the indication of right upper quadrant pain. There were 479 images, including the coronal and sagittal recons, in this abdomen pelvis CT. There are no acute findings in the abdomen or pelvis. The finding was on image 1 of 479. And there it is. There's the pulmonary embolism. So you could have diagnosed this by using your checklist approach. However, you could have also used some secondary signs to help you make the diagnosis. Some secondary signs are present in this case that are the sequela of the pulmonary embolism. First, let's talk about that airspace opacity. So that's the pulmonary infarction. The pulmonary embolism has occurred, it's cut off blood flow to that portion of the lung, cells begin to lyse, intracellular fluid becomes extracellular, gets into the interstitium, perhaps leaks into the pleural space. If that fluid displaces all of the air from the alveolus, then that'll manifest as consolidation. If that fluid is still mixed with some air in the alveoli, then that'll manifest as ground glass opacity. So here the blue arrow is pointing out a pulmonary infarction, and the green arrow shows that small unilateral pleural effusion. Here's another great call case that was submitted. Again, we've got peripheral consolidative and ground glass airspace opacity within the right lower lobe. We have a unilateral right-sided pleural effusion. And if you look at the right hilum, you might be tempted to say, oh, there's some lymphadenopathy there. But if you really follow out the pulmonary arteries in this case, you see that this is not lymphadenopathy, rather that's a large pulmonary embolism within a right lower lobe lobar pulmonary artery. Here's another case that was submitted as a great call. This is a 22-year-old female abdomen pelvis CT non-contrast stone study done for the indication of right flank pain. The radiologist recognized this peripheral airspace opacity within the right lower lobe, and their impression said this: a small region of consolidation in the right lower lobe. This finding is nonspecific but could be secondary to pneumonia, pulmonary parenchymal infarct, or contusion. In contacting the clinician to get additional history, it turns out there was no history of trauma. There were no signs or symptoms of infection, and so pulmonary parenchymal infarct was leading in the differential diagnosis in the patient who had just started oral contraceptives. And sure enough, here's the follow-up chest CTA showing the PE in the right lower lobe. So in this case, the only sign was airspace opacity. And this is a different patient. The finding is in the right lower lobe posterior base, this peripheral wedge-shaped airspace opacity that alerted the radiologist perhaps that's a pulmonary infarction. Let's look at the pulmonary arteries in the right lower lobe. It was a contrast-enhanced CT, but not a CTA. If you look at the pulmonary artery denoted by the green arrow, you can see it's subtly hypoattenuating relative to its companions on the contralateral side. If you put it on liver windows, and you can see that low attenuation filling defect there, confirming the pulmonary embolism in this patient. Another secondary sign you can use is vessel enlargement. If you think about the pulmonary embolism, it's going to travel down the pulmonary artery as far as it can go until it gets stuck. And the arteries are somewhat compliant, so they'll expand a little bit. So let's look at this case. In the right lower lobe, you'll see this pulmonary artery about 1 centimeter away from the pleura, circled by the red. That artery is about 3 times as large as a same branch order companion vessel in the left lower lobe. That's because that artery within the right lower lobe is expanded by the acute pulmonary thromboembolism. Again, in this case, you've got a unilateral pleural effusion on the same side as the pulmonary embolism. Here's another case of a PE on an abdomen CT. In this case, it was detected by the conspicuously enlarged pulmonary artery within the right lower lobe. If you look for a similar branch order artery on the left, you see that this artery on the right is about 5 times the size because it is expanded by that acute thrombus. Again, unilateral pleural effusion on the right. The last secondary sign we'll discuss on an abdomen pelvis CT is seen here. This is a right common femoral vein thrombus. So if you see a deep vein thrombus, think about the natural history of that DVT and make sure you follow it to its conclusion. In this case, there is a large pulmonary embolism present within this patient as well. Those are some strategies on how to diagnose a pulmonary embolism on an abdomen CT. It's a pretty common finding. I've got scores and scores of these cases. So use your checklist approach, look directly at the pulmonary arteries. That gives you your best chance of seeing it. If you don't directly see it, you can use secondary signs to alert you to the possibility of the presence of an underlying pulmonary embolism. We talked about the pulmonary infarction, a unilateral pleural effusion, vessel enlargement, and deep vein thrombosis. Thank you very much.